morning, and Gary's right. We have been trading places for like close to a decade now, so I wonder what I'm going to be doing next. But it's really great to be here this morning, and thank you. I really first want to thank Gary for that introduction and the words of encouragement, because it isn't always easy to innovate in government, but it is a privilege. And I also want to thank John Broyles and the C-TAC leadership for inviting us this year to join the summit again. I think that we had a couple of folks speaking last year as well, and it's a really great opportunity to talk about our work. And I'm really excited because a year ago we couldn't talk publicly about some of the things that we had in the works, and this year I'm able to talk about some of the progress we've made and the new work that we have underway more publicly, so it's kind of fun. The themes for this year's conference for you all, achieving greater health equity in our system, addressing workforce challenges across the healthcare sector, and improving quality for our beneficiaries are front of mind for us at CMS. And so a lot of the themes that you all have been gathering around really resonate, and I think help us also tell us that we're headed in the right direction in our work as well. So in my brief remarks today, I'm going to provide some background on the Innovation Center, discuss the progress in testing innovations to improve care for those with serious illness, and then I'll do a deeper dive on our guide model that Gary just mentioned. It's led by my colleague Tanya Saffer, who I think is going to be joining you all later today. I would like to say that it's a long road. Our director, Liz Fowler, says that payment reform is a marathon and not a sprint, and I feel like that's also true for many of you that have been doing work in the serious illness and palliative care space for many years. And it's sometimes hard to see, but I do believe that we're making great progress in recognizing the needs of people with serious illness and their families, and in looking across at least our portfolio at the Innovation Center to advance care delivery, especially for those from underserved populations. I feel like we are building on the lessons that we've learned over the last decade and really looking across our portfolio at opportunities to improve care for those with serious illness. So as background, the Innovation Center was established in 2010 as part of the Affordable Care Act to test new approaches to care and delivery that improve the quality of care provided to Medicare and Medicaid beneficiaries while holding or even lowering program costs. This is mostly achieved through the development and implementation of innovative new alternative payment models. And the common goals of these models is to improve patient care, to ensure that people have access to high quality care no matter where they are in the health system, and to reward healthcare providers for delivering high quality and cost efficient care. And most of our models, as many of you know, many of you have been involved in them or participants and are familiar with them, they're time limited tests. So we're really testing new ways of delivering and paying for care. Some of our models, as you know, are focused on specific provider types like primary care first, or making care primary, really focused on primary care providers, or ACO models. For instance, in ACO REACH, we have a high needs track for beneficiaries with complex health needs. We also had our Medicare Choices model, or MCCM model, that also focused on those at end of life and hospice providers. Other models test innovations in Medicare Advantage and Part D. Many of you are familiar with our hospice benefit component of our Medicare Advantage value-based insurance design, or our VBID model, through which health plans test whether increasing access to palliative care and better transitions into hospice care can improve outcomes for those with serious illness. And finally, some of our models are organized around a specific health condition, like dementia care management, in our guiding an improved dementia experience model, or guide. I'll be focusing on that model a little bit later today, just in a few minutes in my remarks, and give you guys a little bit of a deeper dive. And for those of you that are interested in more insights into how palliative care and long-term care fits into our broader model portfolio, our Deputy Director, Ellen Lukens, I think is going to be joining you all for a fireside chat this afternoon. So hopefully you'll be able to, hopefully your flights and trains aren't taking off and you'll be able to listen in on Ellen's remarks as well. That's a little bit about where we've been, but where are we headed? And we really believe more than ever, we need the health system, and especially our beneficiaries with serious illness and their families need value-based care to build a more person-centered health system. It is really difficult to meet the needs of patients in a holistic way under fee-for-service payment systems that often, unfortunately, contribute to fragmentation for families. And while it's clear why the current system may not be working for patients, I think we're also seeing increasingly firsthand what it means for providers. We often see physicians, nurses, other health professionals overburdened at a time where they want to be able to provide person-centered care and focus on the patients that need more time. Providers across the health system, as you all are well too aware, are reporting high levels of burnout, especially long-term care providers and those caring, again, for those with multiple chronic conditions. They were put under extreme stress during the pandemic as they cared for those most vulnerable. And while the pandemic exacerbated the feelings of burnout, our fee-for-service paradigm has long taxed our healthcare workforce. I know workforce is one of the themes for this summit. And I think at the Innovation Center, oftentimes we don't have very direct levers to affect workforce, but it is something that's top of mind, that as we're thinking about value-based payment models, we should not only be thinking about improving access and quality and care, but also be thinking about how those models can improve the care delivery system for the providers that are caring for our beneficiaries. And so we are excited to continue to innovate on how value-based payment models can meet the needs of beneficiaries with serious illness and their families. And we really welcome C-TAC and CAPC's expertise and your continued engagement to create more opportunities. So with that, I'm going to transition to talking a little bit about our guide model. I think this offers an example of how we're testing innovations to better meet the needs of a diverse group of beneficiaries with serious illness. Many of the 6.7 million Americans living with some form of dementia are not consistently receiving high quality and high value care. Some of these issues, as you all know, include a lack of caregiver training and recognition. We saw that firsthand in this video, unestablished healthcare pathways, limited coverage of key supportive services, and lack of sustainable payment for a comprehensive model of care. The guide model will test if a comprehensive package of care management coordination, caregiver support and education, and respite services will improve quality of life for beneficiaries with dementia and their caregivers, while delaying avoidable long-term nursing home facility placement and enabling more beneficiaries to remain at home through the end of life if that is what they want to do. And while not a total cost of care model itself, in GUIDE, we are allowing overlap with accountable care organizations, including the Shared Savings Program and other total cost of care models. Targeted models like this need to be able to operate in a broader accountable care environment, and that's why we're testing innovations that can be embedded in different settings, depending on where a beneficiary is. However, the model can also operate as a standalone model, which allows for small providers, rural providers, those in underserved communities, and those new to value-based care to collaborate with other clinicians and practitioners in new ways. The guide model aims to address the key drivers of poor quality dementia care in 5 key ways. The first is defining a standardized approach to dementia care delivery for model participants. This includes staffing considerations, services for beneficiaries and their unpaid caregivers, and quality standards. The second is providing an alternative payment methodology to participants. So once we've set that care pathway, now we need to develop a payment approach that's going to wrap around and make that care pathway possible for everyone that's a part of it. So CMS we're going to be providing a monthly per beneficiary payment to support team-based collaborative care approach. This also includes testing a health equity payment adjustment that's designed to decrease gaps in serving historically disadvantaged communities. We know that there are significant disparities in the diagnosis and treatment of dementia, especially for underserved populations, and one of the goals here is to start to close some of those disparities. This is another example of how we're really trying to use all of the levers available to us in model design to advance health equity. Payment is obviously a big one. Another example is ACO REACH, which includes that high needs track that I spoke about, and Ellen will probably talk a little bit more about this afternoon. We are testing a first of its kind health equity benchmark adjustment in ACO REACH, taking some of those learnings and seeing how we can apply them to this guide model as well, so that we are driving resources to those communities that have been historically under-resourced. The third is addressing unpaid caregiver needs, and 3 and 4 kind of go together. The first is unpaid caregiver needs, and number 4 is respite services, so I'll talk about them together. I think these are 2 obviously very significant innovations that we're testing. We saw firsthand with the video that kicked off the morning, the burden on unpaid caregivers, the choices they have to make day to day. And so we're really excited to see how some of these new options in this model actually are better able to support caregivers and families. So the model is going to aim to address the burden experienced by unpaid caregivers by requiring model participants to provide caregiver training and support services, including 24/7 access to a support line, as well as connections to community-based providers that might be able to offer additional support. The fourth is respite services. CMS we're going to be paying model participants for respite services, which are, as many of you know, temporary services provided to a beneficiary in their home, at an adult day center, or at a facility that can provide 24-hour care for the purpose of giving the unpaid caregiver temporary breaks from their caregiving responsibilities. This is something, honestly, I should be applauding all of you, because that was really made possible because of all of the discussions that we had with C-TAC, with CAPC, with ARP, with other leaders out there that really have helped us understand and highlighted that when we're talking about individuals with dementia, we're talking about a patient and caregiver dyad, and that as we're designing innovations and designing new models, we really need to approach the design that way and be supporting that dyad. So thank you to all of you, and C-TAC's leadership and CAPC's leadership as well. And then the fifth is screening for health-related social needs. Here, model participants are going to be required to screen beneficiaries for psychosocial needs and HRSNs and help navigate them to local community-based organizations to address those needs. In addition to those screenings, our participants are going to be developing and implementing health equity plans, another feature that we're implementing in ACO REACH and across other models as well. To really help organizations that are participating identify disparities in outcomes in their patient population. So it's really an organizing tool to help providers understand, again, the disparities that are present in the populations that they're serving, identify those interventions to help close those disparities, and then track their progress over time. And I'll say that Aditi and the team at the Office of Minority Health have been real leaders in helping the Innovation Center with many of these pieces around health-related HRSN screenings, referrals, our work with CBOs and health equity plans, and it's a really great partnership to have them as a convening resource and group of experts that can help us guide our work as well. So these program design elements hopefully help illustrate how our payment models and how the Innovation Center is trying to leverage value-based care, again, to address workforce burdens and patient and caregiver needs that I think we all recognize are hurting our ability to deliver the best care possible to our communities. And so some of the other things that we're trying to offer through our models, again, not only guide, but our other models as well, is tools and data. We know this is really important. Tools and data are necessary to better coordinate among multiple providers working to serve a beneficiary's holistic needs. The second is payment innovations. I talked about the per member per month fee, the health equity adjustments. We really want to give providers stable and predictable payments that reduce the day-to-day administrative burdens on providers that we often see in a regular fee-for-service system. We're also looking at upfront investments that allow greater infrastructure and data tools and investments that support providers. In the case of Guide and other models as well, we're looking at trying to attract safety net providers and those that are new to value, and providing some of them that are eligible upfront infrastructure payments to help them make the investments necessary to participate in value. And then the last is regulatory flexibilities that let providers offer more comprehensive care for patients in the communities, in this case, for instance, respite care. So really looking at all of the tools that we have in our toolbox to solve the problems that people are bringing forward to us. Hopefully, when it comes to Guide and the other models that we're testing, this means that providers can focus more on the patients that need more attention, they can provide better care coordination, and provide more patient-centered care. And as you can see, we've put, hopefully, as you can see, we've put a lot of thought into Guide, again, informed by many of you here in the organizations here, to really transform this critical area of care, and look forward to hopefully working with many of you in this room as we move towards implementation and ensuring the success of the models. And we're excited to build on the progress of the last several years to continue to drive innovations both at the federal and the state levels that more seamlessly meet the needs of those with serious illness and their families. So thank you all, and I'm going to turn it over to Aditi.
Thank you, Purva. Thank you again to John and the C-TAC team for inviting us to be here today. I'd like to build on what Purva said and share a bit about what we're doing, what we're implementing at CMS across Medicare, Medicaid, and some of our other programs to really align with the themes of today's conference around advancing health equity, addressing what we know to be very substantial workforce challenges, and continuously having our eye on the ball of improving quality of care, in particular for individuals living with serious illness and their families and caregivers. First, on the topic of health equity, I'll start by saying that coverage and access we know to be really foundational levers to improve health equity. I'd like to highlight a range of initiatives and policies that we think really do advance equity for individuals with serious illness. First, I'll just say as a baseline, in the Medicaid program, where, as was alluded to, sort of my home prior to my current role, there are a number of flexibilities that already exist. Health homes, managed care in lieu of services, 1115 waivers, and home and community-based services, flexibilities and waivers. And I realize that may sound like a lot of policy words and that I won't go into grave detail here about, but I'm happy to follow up about or send resources if it's helpful to folks. Any and all of those can be used to help identify and address the needs of individuals with serious illness, and I see some nodding heads for folks that may be familiar with those flexibilities, but I'll highlight some specific examples of coverage of services that may be relevant to you and the patients you serve. First, as Purva mentioned, the coverage of caregiver respite services in Medicaid, a long and storied precedent of doing that across many of the authorities that I mentioned. Focused case management services, so connecting folks to care navigators to help with high burden disease states, and support services to address the health-related social needs, things like nutrition supports, Meals on Wheels is a very common example, housing supports for individuals that sort of live on the cusp of being marginally housed. Shifting gears a little bit to the Medicare program, in this year's proposed Medicare physician fee schedule, which, as folks may know, governs payment to clinicians in the traditional Medicare program, a number of provisions that I would highlight for you to all, again, have awareness of for how we're thinking about addressing some of these issues. The two that I would highlight are coverage of principal illness navigation services and coverage of community health workers. First, starting with community health workers. Yes, and I will echo Purva's thanks to all of you. Please know that I have the extraordinary privilege of standing up here to be an ambassador for this, but it is really you and your work and your advocacy that leads to the process of me being able to stand here and tell you that it's now in proposed rules. So really my applause and thanks back to all of you, and I know many people not in the room right now. With respect to community health workers, as somebody that lives and breathes equity work on a near daily basis, we know that community health workers are often much better equipped to reach individuals and communities in racial and ethnic minority communities, individuals with limited English proficiency, and frankly, folks that just don't trust the healthcare system. And I say that as somebody that is a doctor who has worn a white coat and felt the distrust on the other side. And so bringing others into the fold in the true spirit of multidisciplinary care teams really allows us to deliver, as a system, better care to the people that we are trying to serve. The other service that I would highlight is the principal illness navigation services, and I alluded to this a moment ago, but these are services for people who are diagnosed with high-risk conditions. Think cancer, congestive heart failure, like what we just saw on screen, and really help identify and connect those individuals and their families and their caregivers to appropriate clinical and support services. We also know that clinical care is really but a fraction of what impacts people's health outcomes. Things like social needs, housing, food, transportation, and spiritual health and well-being, right? That is why this year's physician fee schedule and many of the models that Purva alluded to also have a component of health-related social needs screening. And in many cases, including in the Medicaid program and in parts of the Medicare program, the ability to actually connect patients to services to address those needs, be they nutrition services or housing services. We've also seen tremendous innovation through the Hospital at Home program that allows patients with serious illness and others with acute illness and their caregivers more support and flexibility. For folks that don't know, the Acute Hospital at Home waiver expanded CMS's Hospital Without Walls initiative as part of the pandemic, as in an effort to increase hospital capacity and maximize resources during the pandemic. That initiative allowed individually approved hospitals to provide inpatient levels of care in an individual's home to address acute inpatient constraints through leveraging telehealth flexibilities. And for folks that follow along the workings of Congress, The Consolidated Appropriations Act that was passed at the end of last year extended that flexibility through the end of 2024. Yes, again, thank you to you all. That legislation also includes requirements for hospitals to provide data to the Secretary of HHS to monitor quality of care and undertake a study that's required to be completed by the end of the third quarter next year. So, in the spirit of the Innovation Center, in the spirit of testing, we're really trying to learn as we advance and implement many of these policies. And the last thing I'll mention with respect to health equity before getting to some workforce issues is the HHS Office of Civil Rights, in conjunction with the Administration for Community Living, earlier this year released broad sweeping regulation around protections for individuals with disability. And protections specifically against discrimination. The reason I mention that is, as I think many clinicians and caregivers will know, many individuals living with serious illness are also on some form of disability, and things like ramps, accessibility, requirements. I'll give you a very concrete example. A requirement that when you go into a clinic, if there is an iPad or a tablet, that it be at a height that somebody in a wheelchair can access, right? Things that we all know, having lived in this space, really make a difference to people on a daily basis. Next, I'll move on to the topic of workforce challenges, and I will just say, based on that video, based on my observation, I know that we can't have a conversation about workforce without talking about burnout, both burnout among traditional healthcare providers as well as burden and burnout among family caregivers. As we saw in the AARP caregiving video prior to this, right, many individuals who are trying to balance their own jobs, their own health and well-being with the demands of being caregivers. The solution to that, I will say, is multifaceted, and I will give you some insight into, alongside the guide model, some of the other things we're doing at CMS to address those issues. The first is in the Medicaid program, we are constantly in conversation with states and reminding our state Medicaid agency colleagues around the flexibility at the state level for telehealth flexibilities and family caregiver flexibilities that we saw have a pretty dramatic rise during the pandemic because of health system closures or the inability to access quote-unquote traditional settings of care. We've also seen uptake in Medicare telehealth flexibilities, some of which post-pandemic have stuck around. And last but not least, we are focused on improving the quality of care for the people that we serve. In Medicaid, and as folks know, Medicaid is the single largest payer in the country for long-term services and supports, be it institutional or in a home-based setting. We introduced just in the last year, the Home and Community-Based Services Measure Set. So this is the first time in the history of the Medicaid program, in the history of home and community-based services, where we now have a standardized set of quality measures to understand the quality of care that is being delivered to the millions of people that receive these services. Quite a bit of intentionality went into ensuring that that measure set also includes measures of experience, right? We hear time and again about issues of dignity, about issues of autonomy, and those are really measures that I will say traditional quality measures that we think of as process or outcome measures don't always capture those. So really ensuring that the voice of the individual is reflected in the quality improvement and the quality measurement apparatus. And then I'll also highlight in the Medicaid program proposed rulemaking to require states to stratify those measures by race and ethnicity. I think we have heard multiple times sort of the theme that individuals from racial and ethnic minority communities are more likely to be unpaid caregivers. They are very likely to be subject to lower quality care for a variety of reasons. And so we realize that there's a real power in shining a light on those disparities so that we can move forward and actually understand how to close those equity gaps. I'll close by saying that across these three areas of equity, workforce, and quality, your advocacy and your commitment really make a difference. I'll just echo what Purva said. This work really is a marathon. There are sprints along the way in the marathon, but it really is a marathon. And we know that we couldn't do it without you. So thank you for being on this journey with us. Thank you for running alongside us. And thank you for being here today. I hope it's a great rest of the conference.